Your smartwatch says your resting heart rate is 42. 42. That sounds like you're barely alive. Are you dying? Maybe you're one of the healthiest people in the room. Or maybe you have a serious heart condition that needs investigating. Welcome to one of the most fascinating puzzles in sports medicine, the athlete's heart. By the end of this video, you'll understand why the exact same slow pulse can be a badge of fitness or a warning sign that costs lives. First, the basics. Your heart is a pump. The amount of blood it pushes per minute is called cardiac output, and there's one equation that controls everything today. Cardiac output equals stroke volume, the blood per beat, times heart rate, the beats per minute. Remember it, it's the key to the whole mystery. In an untrained person, when they need more blood flow, the heart mostly just beats faster. More heart rate, more output. Simple. But train consistently for months, and something remarkable happens. The heart adapts. It gets stronger, and its chambers get bigger, so each single beat pushes out much more blood. And if each beat does more work, the heart doesn't need to beat as often to do the same job. That's why a trained athlete's resting heart rate drops. Your 42 might just mean your heart became extremely efficient. This is called resting bradycardia, a slow resting pulse. In endurance athletes, it's completely normal. In fact, here's the twist. If a serious endurance athlete has a high resting heart rate, that can actually signal a problem or poor training. There's even a law behind it, the Frank-Starling law. More blood returning to the heart stretches it, and a stretched heart contracts harder. Train it, and the whole system becomes a more powerful, more economical engine. And no supplement lowers your resting heart rate. Only consistent endurance training does. Now it gets interesting. Not all athlete hearts adapt the same way. It depends on the type of training. Endurance work, running, cycling, swimming, is dynamic exercise. It's a volume overload. Lots of blood flowing through, over and over. The heart responds by enlarging its chambers and increasing muscle mass to handle the volume. Strength work, heavy lifting, is static exercise. That's a pressure overload. The walls of the heart thicken to push against high pressure, but the chambers stay smaller. So a runner's heart and a powerlifter's heart literally look different. Different training, different remodeling. And here's a detail for the curious. In women, the heart enlargement tends to follow the endurance-style pattern for hormonal reasons. All of this shows up on an ECG, the electrical trace of the heart. The athlete's heart has a recognizable signature, that slow sinus bradycardia, taller electrical signals because athletes carry little body fat, a slight delay in electrical conduction, and a few other quirks. But here's the problem. If a healthy athlete's ECG already looks unusual, how do you tell it apart from an actual disease? That is the question. And it's where this stops being trivia and starts saving lives. There's a dangerous overlap doctors call the gray zone. On one side, the healthy athlete's heart. On the other, a disease called hypertrophic cardiomyopathy, where the heart muscle thickens abnormally. The problem? On a single scan, they can look almost identical. Thickened heart walls in a healthy lifter, or thickened walls from a deadly disease. How do you tell? Here's the elegant trick. You make the athlete stop training completely for 3 months. Because a true adaptation is reversible. If it was a healthy adaptation, after 3 months of rest, the changes fade. The bradycardia, the enlargement, they normalize. The heart returns to baseline. But if it's a disease, 3 months of rest changes nothing. The abnormalities are still there. That's your answer. There's a second clue too. In a healthy athlete, the heart still relaxes and fills perfectly between beats, what doctors call preserved diastolic function. In the disease, that relaxation is impaired. And to be clear, no pill distinguishes a healthy heart from a diseased one, and none prevents cardiomyopathy. This is a job for an ECG, imaging, and a doctor. So why does this actually matter so much? It's just a slow pulse, right? Because getting this wrong is one of the leading reasons young athletes die suddenly. Sudden cardiac death in sport is rare, but devastating. And it's why all of this exists. Let me give you the facts straight from the research. There's an academic dividing line at age 35. Under 35, athletes who die suddenly usually have a structural or electrical heart problem they were born with. Over 35, it's typically coronary artery disease. Worldwide, the single most common cause in young athletes is hypertrophic cardiomyopathy, that exact disease hiding in the gray zone. The one exception is a region of Italy, the Veneto, where a different genetic condition dominates. Around 90% of those affected are men. And strikingly, 96% happen in recreational or amateur sport, because elite competition is far more medically monitored. In Spain, most cases occur in the most practiced sports, football and cycling lead, followed by endurance running. In the US, it's basketball and American football. It tracks with whatever people play most. So could doing too much endurance sport actually hurt your heart? A subtle but important point. Exercise is protective, up to a point, but some research suggests a dose response, like a medicine. Push extreme endurance for years with no rest, and risks can creep back up, things like atrial fibrillation in middle-aged endurance men, or cardiac fibrosis, scarring of the heart muscle. The encouraging part, a lot of that scarring can reverse if the athlete rests, which is why recovery isn't optional, it's part of the training. You prescribe rest like you prescribe the workout. So how do we stop these tragedies? 3 pillars. First, pre-participation screening. In the European model, an ECG before competing is mandatory. The US model skips the routine ECG and uses a questionnaire instead. The European approach catches more hidden conditions. Second, CPR training. Teaching it in schools and to the public means a bystander can act in the critical first minutes. Third, public defibrillators, AEDs placed around cities. And here's the number that should convince every city council on earth. If an athlete in cardiac arrest gets defibrillated within the first 5 minutes, 89% survive. 89%. Those wall boxes you always ignore actually save lives. Knowing where your nearest one is might be the most useful thing you learn this week. So let's bring it home. 1. A slow resting pulse in a trained athlete is usually a sign of a healthy, efficient heart. 2. But it sits in a gray zone with real disease, and the 3-month rest test tells them apart. 3. Screening, CPR, and AEDs are what turn a tragedy into a survival story. So that 42 probably means your training is paying off. But if you ever feel faint, short of breath, or your chest does something strange during exercise, you don't guess. You see a doctor and get an ECG. Because the best thing for your heart is consistent training, real recovery, and knowing the warning signs. No scoop required. If this helped the science make sense, subscribe, and go find your nearest defibrillator.